we can refresh our memories and have a transition into the material. I think we have about 6 hours of time left. And there's a lot of things to cover, so if there's something people want to talk about, particularly as we get into the afternoon and we haven't covered it, please bring it up and we can continue to try to cover things that are particular as interest to people. So let's go back and start with the motor potentials. And, we've talked about the anatomy of the spinal cord and the fact that you have the dorsal column pathways, and the lateral cortical spinal pathways are the ones that we're most interested in because they activate the limb muscles. And the kinds of things we can measure are the I waves and the D waves. And we'll look at those. And then the effect of the I waves, or primarily the I waves, is to produce these compound muscle potentials, which is what we normally record. Again, the theme of synaptic architecture is very important. So when we think about the somesthetic system, we think of a series of synaptic junctions. When we think about the motor pathway, we think about a series of synaptic junctions, starting at the cortex, down to the anterior horn cells, to the muscles. So these multiple layers of synaptic junctions, and that's what produces the issues with respect to how sensitive these responses are to different anesthetic regimes, is the fact that there's all these synaptic structures you've got to work through. This is just a general scheme, stimulating at the head, producing efferent activity, which can be recorded in 3 different ways: compound muscle potentials, compound action potentials through a peripheral nerve, and D waves, for our purposes, recorded directly from the spinal cord. So 3 different ways you can try to get at this data. All of them have strengths and weaknesses that all can be helpful in one way or another. Stimulation parameters, we talked about this. I make this point over and over again. Hopefully everybody's sick of hearing it. Synapses are important. Okay. The stimulation parameters to get around the effects of anesthesia, the short duration multi-pulse trains, we call them bursts. This idea was developed originally by a physiologist named Amasia, and he worked in the 50s, late 50s, early 60s. And he did a lot of studying of the motor pathways and figured that if you use this kind of bursting pattern, you could drive them quite well. So let's just jump down here. Stimulation parameters. This is always a big topic. I get phone calls from people all the time, wanting to review how we do this. So our stimulation rate, we talked about this from here to here. That's 0.89 hertz, or a little over 1 second, 1.1 seconds. Some people will use more, a longer time between bursts of pulses. So it's almost what you get your personal experience with that drives that. The thing you don't want to do is you don't want to make this time too small. You want to keep it around a second or longer. Okay, the burst frequency, we usually use 250 hertz for this burst. 500 hertz is probably the highest that people use, but occasionally we'll talk to someone that we use 600 or 700 hertz. I'm not sure they're getting benefit when they go that high for the burst. And if you think about it, if you're stimulating at 500 hertz in a small burst like that, the inner stimulus interval, the time between each pulse and the burst, is only 2 milliseconds. So that's getting pretty tight. So there's some number in there which is best for each patient. We normally use the 250, and sometimes we'll go up a little bit, maybe to 300, depending on the patient. The burst duration, we like 20 milliseconds, and when we're looking at the data, you can see you've got a burst at the beginning, and then you're separated from the motor potential, so you can clearly see the difference between the two. You're not trying to look at a motor potential and there's bursts of stimuli occurring right at the same time that the motor potential is. So we kind of picked that 20 milliseconds to give us some time in there where we can separate things out. That gives you 5 to 10 pulses in a burst. When we talk about this, you get this summation. Pulse duration, we tend to use 0.2 milliseconds for everything. Now when you get patients that have a lot of pathology, then you can increase that pulse duration. We never go wider than 0.5 milliseconds. Some people will try to go wider. There's an issue there. If you think about the amount of charge being transferred to the patient, so the number of electrons being transferred, the number of charged particles, it's the product of the amplitude and the width. Okay, so remember, milliamps is actually a number of electrons being transferred, and then so the amplitude and the width tells you the total number of electrons being transferred. So this gives you a reasonable number of electrons being transferred to excite things, but not so many that you can hurt the patient. And then the maximum intensity will go up to 200 milliamps. I think in the United States, there's an organization, the FDA, and they approve things. I think they're the highest value I've seen them approve is 1,000 milliamps. I don't know why you would ever need to do that. We typically are stimulating around 100 milliamps, most patients, with a pulse width of 200 microseconds, 0.2 milliseconds. So I don't know why people need those huge values. So the stimulation parameters are extremely important. Okay, just to review where you stimulate at. We stimulate between C3 and C4. So if you remember, we didn't spend a lot of time on this, but the 1020 montage, the line through the vertex between the auditory meatus, defines where that plane is, and C3 and C4 are on the more lateral edges of that plane. People will sometimes put electrodes all the way across that plane, and they'll put on some other ones. We get pretty good results just keeping it at C3 and C4. The responses in general will be produced contralateral to the anode electrode. So whichever electrode, if C3 is your anode electrode, C3 is on the left side, so you can expect to see the motor responses produced on the right side. Now, occasionally you'll get a patient who, it doesn't matter which side is their anode, they're going to respond appropriately, and we think that's because of the thickness of their skull, the musculature they have, all the things that interfere with the flow of this current through the brain. So if you set a patient up and you stimulate between for your transcranial responses and you get a response on all the motor tracks at the same time, that's great, but it's also unusual. You can more likely expect to see the side of the anode being the most pertinent side. These alternative stimulation sites, C1 to C2, they're a little closer in. If you think about the physics, the further out you are, the deeper you're going to go, the closer in you are, the less deep the currents will go. And then people will also stimulate CZ to FC, so they stimulate in this direction. So that's down the center plane. I haven't found that to be particularly useful. So you'll see people, when you look at papers or figures, people will say, oh, we did this, and they have reasons why. And hopefully one of the things you're seeing, you can do a lot of things a lot of different ways. And, if you get good results, it's fine. Again, we were talking about recording. We use, again, subdermal needle electrodes. Put a pair in each muscle group. You don't need to use, big EMG needles or anything like that. The subdermal needles work quite well. So they're kind of centimeter long. Same ones you saw, we put in the medial rectus. Those same kind of needles work quite well for doing this kind of recording. The fine motor muscles have the largest representation in the homunculus, so those are the areas which are easiest to excite. So, if you have to record from a limited number of muscle groups, pick fine motor muscles. Again, we tend to, for most cases, we'll record from 2 muscle groups in the lower extremities and 2 muscle groups in the upper extremities, because they really give you a good representation of the entire corticospinal tracts. Some cases, and I'll show you some data where we'll record 9 or 10 muscle groups, but it's for very particular reasons. It's not the general situation. So generally you can do quite well with 2 muscle groups from upper extremities, 2 muscle groups from lower extremities on each side. So you want to do bilateral recordings unless there's some particular reason why you want to do predominantly unilateral recordings. So just a quick review. This slide makes the point about the anodal stimulation. So here we have, this is the muscle groups on the left side. In this case, we have one muscle group from the upper extremity, one from the lower extremity. This is the right side muscle groups, and you can see in this case the anode was on the right brain, so the anode was at C4. By the way, we measure using the 1020 system, so as good as our measurements are, we're trying to be where the 1020 system says those sites are, because that 1020 system actually is a fairly good representation of where the underlying brain structures are. Not perfect, but good. So we actually do measure this, we just don't stick them on and hope we're in the right place. And that's an important thing. So here you can see the anode on the right brain, and we're getting muscle responses on the left brain, just as you would expect. This is I think these are a second apart. If you can see the times, you can see the burst here, so the burst of stimulus, and then the evoked compound muscle potential from the transcranial stimulation. So upper extremity, lower extremity, nothing from the muscle groups on the right side. Then we reversed, flipped the anode, and we're getting muscle groups on the right side. This is the upper extremity, lower extremity, and nothing from the left side. So that's pretty much what you expect to see. And you shouldn't be surprised if you see this kind of activity, because that's the standard thing you're going to see in most patients. What we can do is we can stimulate right side, then flip automatically and stimulate left side. So when you look at the data, it appears as if you're stimulating both sides simultaneously, but we actually put in pairs of electrodes and flip them back and forth automatically. So it looks like you're doing everything simultaneously when in fact you're not. There's a time delay between it. So is this clear? This is a very important point, this anodal stimulation concept. I'm going to spend a couple of minutes on this. Yesterday I just ran past it really quickly. So one of the questions that we were interested in was what are we actually stimulating when we stimulate transcranial? Because kind of in your mind you've got this idea that where you're stimulating the motor cortex, but we wanted to know if we were actually doing that or not. And so that's a very hard thing to determine experimentally. So we built a computer model, and basically the model solved the equation that describes how these electric currents are distributed through the brain tissue. And we got a tractogram of someone's cortical spinal tract, one of the guys in the group, and we put that in the model, got it all aligned geometrically correctly, and then computed where the highest field strengths were at. Remember we talked about the electric intensity field strength. So the point where they're the highest is the point where you're most likely going to stimulate something. And it turned out that the highest points would not appear on the cortex. These are where the stimulating electrodes were. They were not in the area directly where motor cortex is. Rather, they were down on the cortical spinal tract itself. So, in those projections. So, if you're doing an operation, where the goal of using the transcranial motor potentials is to directly protect the motor cortex, then you're better off doing direct stimulation of the motor cortex with a handheld stimulator of some kind than you are trying to do transcranial motor potentials. Their real utility is in protecting the cortical spinal tracts, either in the brain itself or when you get down into the brainstem or into the spinal cord, but not at the motor cortex level. And that's an important thing to think about, depending on what the operation is and the goal of the operation. So this was a computational model that we put out a few years ago. We talked about contraindications. Epilepsy and seizure disorders are a contraindication. I personally have never seen a patient who has had a seizure disorder be put into seizures by transcranial motor potentials, and I have not seen, I think I've seen one report in the literature, which I think was kind of suspect. The idea there is that you're going to cause kindling. Kindling is a phenomenon where you drive an unstable membrane into instability. But it doesn't seem to actually work that way. But in the United States, we're very sensitive to these kinds of issues. So we'll discuss this. I call these all relative because the decision about whether or not to use this technique, given these things as contraindications, are a joint decision on the part of the surgeon, the physiologist, and the anesthesiologist. And you want to avoid things. Now, pacemakers are a bigger problem because I have seen pacemakers get reset from the currents flowing through the body. So, in general, it may not cause a severe problem, but if you have someone who has a cardiac pacemaker that's pacing their heart at a certain rate, and it gets reset to a lower rate, they're going to go to whatever their baseline rate is without the pacemaker. So you really don't want to do that. So we always have the discussion: do you want to do this? If you want to do it, is it better to turn the pacemaker off and have them start at whatever their baseline rate is, rather than whatever rate they're being paced at? The things I worry about the most are these implanted intracranial devices, the shunts, the vascular clips, electrodes. These are, by the time the fields get to the brain tissue, they're not that strong, but it doesn't take a lot to change the orientation of a clip or to change a small change in the direction of an electrode, of an implanted electrode. And sometimes small differences there can make a big difference in terms of results. So to me, these are the most important contraindications, to make sure that you've discussed with the surgeon that that this is something you've got to consider. Is the relative value of doing the transcranial stimulation appropriate given the fact the person's got a clip or an aneurysm or something? So, and that's something the surgeon's got to understand and think through about what the risk profile is for him in that particular operation. So, again, I put these all as relative. Some people will say they're absolute. I think they're relative. I think the things you need to discuss and be clear about. Complications. Tongue lacerations. This is the most common complication secondary to transcranial motor stimulation. I assume everybody's done TC, transcranial motor potentials. If you look at the patient, they're not draped. It's like hitting their head with a hammer, repeatedly. And they're moving. Their muscles of mastication are being continually stressed, and you've got to, I cannot emphasize this enough. I never want to hear that anybody didn't put a bite block in the patient that were doing motor potentials. And I got a call one time, I was telling Dr. Clyde about this, to go up to a hospital in New York to evaluate their monitoring. And I said, well, why do you want me to come up? And he said, well, we had a patient bite his tongue off. And he bit off part of his tongue. Well, I got up there and talking to people. Oh, we didn't put a bite block in because we thought the patient had an endotracheal tube and that would be sufficient. No, it isn't. You got to put the bite block in. Please, if you learn anything from this part of the discussion, put a bite block in. Cardiac arrhythmias can be induced, movement-induced injury. This can come in several different ways. And you can tell I'm risk adverse. The first goal is not to hurt the patient. You got a patient in head pins. They're also relaxing, and you're hitting their head with a hammer. Basically, you're going bang, and that's what you're doing. Okay, you can induce movement in the head pins, and I don't know how many people have seen patients come out of a head pins, but it's not fun to deal with that. So you've got to really be aware of this. You've got to work with the residents or the surgeons to make sure the head pins are really positioned correctly against the planes of the skull, and you've got to watch that. And then, depending on the patient, you can get some big extremity movements. Sometimes these are not, and that's where you end up adjusting the strength of the stimulus. You want to have a strong enough stimulus to get a response, but you don't want to have them flailing all over the place. So this is really important. Number one, I'd make that number two. The seizure issue, it's talked about all the time in the United States. I personally have never seen one induced from transcranial stimulation as opposed to direct cortical stimulation. But it's got to be in the potential complications you think about. Scalp burns at the stimulation site, again, people report it. I have never seen it, and I don't know actually how it happens, given the level of isolation that's built into the electronics. So you've got to be careful. You've got to be aware that that's a complication. You've got to know about how the electronics you're using are isolated. So the idea of isolation is to minimize how the current spreads, and you don't get into the high current regions of the power system. But if your system's isolated right, you shouldn't get scalp burns. And the last burn I saw in this area from electrical stimulation was in 1979 or 1980, where the hardware available in those days did not have isolators built into it. So, but it's possible. Jaw fractures, again, think about what you're doing. You're hitting this poor person's head with a hammer, and it's putting a lot of stress on the bones, and people have reported jaw fractures. Again, I've never seen one. I think if you appropriately pick your stimulus parameters, you're not going to have that happen. I have a woman who calls me from one of the hospitals in New York occasionally, and she'll say, "Oh, we want to do motor potentials at, I mentioned you can go up to 1,000 milliamps and 1,000 milliamps, and we want to do them at 700 hertz, and we want to do them at 500 microsecond pulses." And I talked to her, I said, "Why do you want to do that?" "Well, I want to see a response in every muscle." And my thing is, why do you want to see a response in every muscle? It just doesn't make any sense. And something like that, I worry about that you can break a bone. I mean, these are big forces at work. We're not talking about little forces, particularly on the things on the periphery, on the facial musculature. You're injecting this current. The current we talked about, the current's going to try to go in the path of least resistance. The path of least resistance is not through the bone, the muscle, the bone, and the meninges. It's just a flow through the muscles and the skin. So, most of the energy you're applying to the patient is going to excite all this external musculature, which is really torquing these bones. So think about this. Be a minimalist. Don't appreciate the fact that you're beating this person on the head with a hammer. I can drive that home. Effective anesthesia. This is the biggest problem with interpretation of motor potentials is the effects of anesthesia, and these are extremely sensitive to anesthetic regimes. They're easily suppressed by the inhalation agents. So we talked about the isoflurane, the sevoflurane, and desflurane. These gases just have an incredible ability to suppress motor potential. So the protocol we've worked out with the anesthesia team we work with is that, as I mentioned the other day, we'll start at a MAC of less than 0.5%, and then we'll titrate it either up or down, recognizing the fact that the MAC is just the group statistic, and you've got to find out where that individual patient is at. We would prefer, if we could do this, is to just do TIVA. So no, just totally intravenous. And I don't know if you do TIVA here or how you do that.
TIVA?
The same.
For transcranial MIPS, of course.
Yeah, great.
The best technique.
So it's hard for us to get, but for some reason the anesthesiologists all want to have some gas on board. So, yeah.
It depends on the head of the anesthesiologist.
Can you come work in Pittsburgh?
Sometimes. In the dreams.
Propofol, of course, is a sedative. Fentanyl. As I mentioned already, the biggest thing with getting over the effects of anesthesia is the use to the person trained. If you try to use a single stimulus, then you will have to go up to 1,000 milliamps or 1,000 millivolts to drive a response, and it won't be as nice. So bursting trains combined with good anesthesia get you over this problem. This is an example of the effect of isoflurane on transcranial motor potential. So we've talked about what this is. This is an upper extremity response. This is a lower extremity response. Here's our little bursting pattern. You can see it at the beginning. These were done a second apart. 21, 20. Actually, these are 2 seconds apart. 21, 23, 24, 1 to 2 seconds apart. And so at this point in the operation, the propofol was at 100, the REMI was at 0.4. So over here, they decided to decrease the propofol, decrease the REMI, and turn the ISO on up to 0.3. And you can see just that small change. I mean, that's not a big change. And you can see the lower extremity responses were really totally suppressed by that very small change. And the upper extremity responses were, I'd say, decreased by estimated 70 to 80%. So these are on the same scale. I think these are 600 microvolts per division. These were at 100 microvolts per division. Same thing. So you can see the powerful effect of just a small change in one of the inhalation agents. And if this effect is then amplified by the patient's age. So if the patient's an older patient, that effect can be larger. So it appears to me the way this happens is there's like a threshold phenomenon. You might go 0.1% and you don't see any difference. 0.2% you don't see any difference. And 0.3% you see a big difference. You know, if everybody here uses TIVA, I'm ecstatic for you. But be aware of this if you're somewhere where they use other things. Motor potentials in pediatric patients require a higher stimulus. This happens to be in terms of volts. This is old data. And this is the patient's age. So you can see when you're down 1 or 2 or 3 years, the voltage has to be higher. As you age, the stimulus intensity will fall off that you require to produce this. This is a general concept. Don't try to ascribe the numbers of this line to, you know, what may happen with any individual patient, but it's the general idea. If you're working with a child 1 or 2 or 3 years old, it's going to take a higher stimulus intensity to produce a motor potential than it will be if you're working with someone who's 10 or 12 years old versus someone who's 30 or 40 years old.
Why is that?
I think it has to do with the development of how the nervous system develops, because the nervous system really isn't developed until you're 8 or 9 or 10 years old. So you've got the synaptic architecture, of course, which is always developing through our entire life, changing. And then there's the whole myelination process, which is
I was thinking
changing
in terms of resistance and impedance with the skull and scalp.
Well, I'm sure that
if it's smaller.
it should be thinner.
It should be the other way.
Yeah,
I know,
it should be the other way if you think about it strictly from that electronic viewpoint of the skull. So this, I think, has to do with the maturational effect. And there's actually a similar effect, which I didn't mention in the SEPs, that, you know, people that have studied, we've published some data over the years that show people tracked from like a month of age out to 10 years of age. And you can see the stimulus parameters changing, and you can see the architecture of the response changing as they mature. So by the time someone gets to 8, 9, 10, they've got a pretty mature response, but early on it's different, and you can see the cost, and the same thing happens here. So this is, in terms of the operating room, it's more important to understand this about MEPs, because SEPs are not likely to give up. The other thing which is interesting and to be aware of is this phenomenon called anesthetic fade. So what this shows is the duration of the anesthesia and the threshold voltage change. Okay, so I don't know how long the operations are that you're involved in, but we do many operations that go 10, 12, 14 hours. Luckily, people aren't doing the 30-hour operations anymore. They're staging those now. But you can see what happens. In a normal subject, as time goes by, you actually have to adjust the stimulus intensity to maintain the same response size. In a patient who's myelopathic, you have to do the same thing, but you have to increase it by more. So this to me is always a dilemma. Okay, it's a dilemma. This phenomenon is going on. If an operation is going to go on 6, 7, 8 hours, which is not unusual, you're going to expect to see this accumulative effect of anesthesia. But as I mentioned earlier, I don't like to adjust intensities to compensate for decreasing amplitude because it may mask what we're interested in. In fact, it could be producing an injury and you're masking it because you think you're dealing with the anesthetic phase. So we're very, very slow to adjust because of this anesthetic issue. And we will preferably not adjust the stimulus intensity. We will only do it if the operation's gone a long time. It's clear in our minds that the effect we're seeing is from anesthesia, and then we will do a minimal adjustment. So something you need to be aware of. How you manage it is going to be based on your experience and the kinds of operations you do. But be slow to adjust the stimulus parameters based on these kinds of changes, and don't expect to see this till a number of hours into the operation. Okay, so epidural responses, this is just to represent what they look like. So remember we talked about the I waves and the D waves. Well, these are recorded epidurally, and this is the D wave here. You can see this data was recorded. I forget who actually did this. It was at 1500 volts. That's the D wave in that region. This activity here are the I waves. If you can record directly from the spinal cord, then you can see, you can just do the D waves and you can have the patient muscle relax in it. You don't get the I waves. I think I've got an example here. Yeah, this was actually from veterans stuff. So you can see, in this case, they put an electrode between the vertebra. The D waves persist. We record these actually using the same kind of contact grids that we use for recording from the cortex. So the surgeon, so you can only do this in operations where there's a laminectomy done. So the surgeon can then slide the grid down over the cord. Now we like to use there's another recording technique people use, which is a fine wire recording electrode, which is slid down. The problem with the fine wire is it actually doesn't cover the entire cord, but the grids will cover the entire cord. So you can see the activity from both sides of the cord, and you can actually tell which side of the cord is active and which side isn't. Remember, we talked about the cord having the width of a pencil. You know, it's not a big thing. You know, that's the size of the spinal cord. So the grids, when you slide them in, the contacts on the grids are as wide as the cord, so you can see both sides. And we think that makes for a good recording technique.
I have an question. Do you have problems with epidural veins when you're putting this cortical grid down the cord?
We haven't, but it's definitely possible. The surgeons have been extremely.
These are intradural?
Yeah. Yeah, we actually put them intradural, not.
Subdurally.
Yeah, we put them subdurally.
Ah.
So we only use these with intramedullary.
We do quite, in the United States, we do a lot of spinal cord stimulators. Are you familiar with those for chronic pain? Those are all epidural paddles, and I've never seen epidural bleeding sliding those in.
But it's very thin, and this grid is very, it's like a plate. Yes?
Well, no,
they're really thin.
very thin also.
Really
Actually, there's some downstairs. Maybe that bag I gave you, there's some. Maybe later we can get some of those and I can show you.
We're talking about cortical strip.
Yeah.
Yes?
Yeah.
And how much leads from this strip?
We use four contacts.
And all these four contacts are subdurally
Also,
positioned.
Yeah.
Oh, okay.
And it's just one piece, and it's probably a fraction of a millimeter thick. It slides in very easily. There's not been a problem that I've heard about with any of that place. And it works really well because you're across the entire cord. Yeah, they work well. I think I was just thinking of the spinal cord stimulators too. We do a lot of those, and I've never been aware of.
I mean, it's a risk, but it's not a frequent problem.
Yeah, I was trying to just remember if we ever had a problem. The only problems I've seen with placement of those things have been the cord actually getting injured from an instrument getting pushed into the cord.
Or they can buckle. You know, they're rubbery and they can buckle and push it up.
So the D waves can be recorded with the patient on muscle relaxant. Now there's an issue with respect to where on the cord you can actually record those because of what we were talking about. The fact that the corticospinal tracts are myotopically organized, somatotopically organized, whatever word you want to use. And so as you go further rostral in the cord, the size of the corticospinal tracts becomes smaller. And so typically you can only record D waves in something above T10 or higher. So T10, T9, somewhere in there is going to be a point where you're not going to be able to get a response. So this is best a technique in intramedullary tumors that are in the upper thoracic or cervical area, or maybe mid-thoracic. But you know, if you've got something that's down in the L1 level, don't expect to try to do D waves, or if you're at T10, don't expect to try to do D waves. It's not going to work for you. So that's worth thinking about. So just to summarize those, used during operations in which there is access to the cord. So you really want to be able to get to the cord. We only use them in intramedullary tumors. Any change should be noted. So the D waves are there or they're not there. Same way we interpret the transcranial motor potentials. They're either there or they're not there. The things you got to worry about, recording electrodes can move and then therefore produce an artifactual signal. So kinds of things we deal with all the time. Right-left distinction is difficult. I like these grids because if you know what you're stimulating, and you'll see a response. Obviously, from the recording itself, you can't tell, but the fact that you know which side your stimulation is being applied to, and infers which side the response is coming from. And I made the point, very difficult to use below T10, just because you don't have a volume of tissue that's producing a signal that can be. Now that can easily change as sensitivity becomes better in the kinds of equipment that we have. Again, just going to switch just to EMGs for recording from the cord. Again, the same kind of theme of what we've talked about with recording from all EMGs. Spontaneous from distal muscles. The activity is associated with nerve root or nerve mechanical injury. You want to know, you want to have clear in your mind what nerve roots you think are at risk and then what muscles are the best ones. This is passive recording, free running. We use subdermal needle electrodes again, and the stimulated activity is the compound motor potential. So the theme here is to try to think about how do you make things as internally consistent as possible. So it makes it easier for people to learn good technique and do it over and over again. Again, just we've talked about this in different ways. So it's an indicator of motor axon stimulation injury. I like the idea of hitting things with hammers. So you've got a nerve, you've got some blunt trauma to it, which is going to produce some change in the conductivity properties, and you're going to see that represented as a burst of activity. So, to try to get this down to thinking about it at a level which is very fit. So, this is kind of interesting because it gets at some of the injury factors, some of the things you got to think about. So if you've got a blunt trauma, so you can produce trauma. If you think about this, you can do it in certain ways. You can take a blunt instrument and you can slowly press against the nerve. And at the end point, you can produce a significant trauma, or you can hit the nerve rapidly with an instrument. Okay. So the degree of trauma at the end point may be the same, but what you're going to see physiologically as the trauma is happening is different. So the number of axons recruited or maybe recruited isn't the best word, the number of axons being affected by a traumatic event is proportional to the rapidity of the mechanical stimulus. So if you hit a nerve rapidly, you're going to produce a larger traumatic event to that nerve than if you slowly compress it. Now, at the end point, if you do a slow compression for a long time and it's continually building up, the end point result may be the same, but the immediate effect is proportional to the speed at which this mechanical event occurs. The degree of the injury is related to the energy of the injury source. So remember, first day we talked about the concept of what's energy. Its energy is force times distance. So you can just physically picture this. You hit a nerve. If you hit the nerves with a certain amount of force, that's part of the equation. But how far into the nerve do you go? that force times that distance into the nerve is the energy being transferred to that nervous tissue, which is therefore disrupting the nervous tissue, and it will produce a different grading of injury. So these are all things you've got to somehow think about, and they're very hard to think about in the operating room because there's a lot of stuff going on, and when you're trying to think about what the injury is, you kind of want to think through this chain of events. The impacted axons maintain this local membrane conduction, which can result in this repetitive firing. So that's when you see these bursting patterns, bip, 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 bip. And then failed accommodation can play a role, so in repetitive firing. So accommodation is this idea that you provide a stimulus to a neuron or an axon, and the threshold of the axon will change, but it will adapt to the stimulus that it's getting, so it accommodates to it. But if a neuron is injured, then that adaptation mechanism fails. We call that failed accommodation. And that can play a role in repetitive firing. So that's sometimes when you see the longer bursting patterns. And populations of intraspinal axons can be sequentially injured over impulse time. So the idea there is you can start with an injury which is fairly focal, and if you maintain the source of the injury, you can the effect of the injury can spread through the surrounding neighborhood of axons. So what could be a very focal injury can then become a wider injury, and you'll see more and more of the neurons participate in the expression of that injury. I don't know if that makes sense to you or not, but it's the idea that things are topologically recruited. And you can see that in the data in the operating room. Sometimes you'll have one particular muscle start to fire, and then several minutes later another muscle will start to fire that's innervated by a root close to the muscle that's being by a root that's innervating the first muscle. So there's some kind of spread going on of the injury. These things aren't projecting real great. I'm sorry about that. So these are lumbar nerve EMGs, and you can see two things here. This is continuous EMG, again, the way we like to look at it. These are, I think, 4-second windows. And you can see the irritation activity here and how it dies out eventually. Very clear stuff to see. It's not hard to recognize. It's harder to figure out what it represents. And then these are evoked EMGs. I think these were from pedicle screw placement. And I can't actually see which muscle groups those were, but there were a whole bunch of muscle groups, and you can see there's some strong compound muscle potentials being produced by, in this case, stimulation of pedicle screws. So again, the same kind of stuff we looked at with the cranial nerves. I can't, the point I was trying to make earlier is these techniques that you apply to cranial nerves for continuous EMG and for compound muscle potentials. The same things apply to spinal nerves, spinal muscles. And there's very little difference between H reflexes. We just wanted to talk briefly about that. So we have a stimulus on a peripheral nerve, flows in through the posterior horn, comes out through the alpha motor neuron, and excites the muscle. And you see the direct response, but then you see this H reflex response, which is delayed, and that's the latency there. This is kind of just to make it a little more physically realizable. You know, you're stimulating somewhere and you're recording somewhere, and you've got all these distances to travel through. So that's why there's these delays in the latency. We don't use a lot of H reflexes. Once in a great while we'll do them. I know some people use them a lot. I personally haven't felt a lot of value in them. So anyway, these are the tools. We skipped over the anatomy quickly because we ran out of time. But talked about the tools for monitoring the function of the spinal cord and the effects of anesthesia on these tools, which is very, very important. I mean, it's got to really be a team effort to apply these things appropriately. So